This week on the BackTable podcast.
How do you know it's a benign stricture and what does it mean? I mean, I think typically we're relying on a certain appearance of narrowing to surmise that it's that type of stricture, where it looks like a classic benign stricture, but it's actually not scar tissue. It's something else. There's a stone there. It actually isn't intrinsic to the bile duct. There are other etiologies that can cause problems that similarly result in the appearance of biliary dyskinesia and cholangitis. And endoscopy is such a higher sensitivity evaluation for what the problem is. And we are a bit naturally married to 2D fluoroscopy. That's where we come from. It's a good initial stratifying tool. But if you've got endoscopy, you can do a much more higher sensitivity evaluation of what the problem is. So the answer today is, I think if you got the endoscope, just confirm that it's a benign stricture and not something else.
Okay. So it sounds like your threshold's getting lower and lower these days.
Yeah, exactly.
Today, we're going to be talking about biliary strictures. We have Dr. Premal Trivedi here with us. So for the audience, I'm hoping this is going to be part of a multi-part series that we're going to do for biliary interventions. Michael Barraza has already recorded an episode with John Smirantopoulos about endoscopic gallstone treatment. That's probably going to drop by the time this one actually comes out. But in short, we have a lot of biliary topics that we want to explore, and there's a lot to cover. So this is just going to be one of a couple, or one of a bunch, hopefully. All right, so today, biliary strictures. Premal, will you introduce yourself? Tell us about the practice.
Sure, yeah. Thanks for having me, Chris. I'm Premal Trivedi, Chief of IR at the University of Colorado. We're a big transplant center, so biliary issues come hand in hand with that. Our practice comprises, obviously, of a number of patients who need liver transplant, kidney transplants, and obviously all of the standard stuff that we see at academic medical centers.
And how many sites?
So we've got the University of Colorado Hospital, that's the academic mothership, if you will, and we've got a fairly large footprint here. On average, we have about 9 to 10 docs here. We've got a community hospital, Highlands Range, and we also have a couple of JV partnerships. So we have an outpatient-based lab, OBL, and it's a little bit unique. It's actually an enterprise that emanated from the department entirely. And we have a JV partnership with Fresenius for ASC, where we take care of dialysis patients and obviously anything else that we want to bring there. That's current status. You know, every year we seem to be expanding, and I think that's the norm these days.
I totally agree. Every time we talk to somebody about their practice, like one year it's like 17 providers, and the next year it's like 25. Everyone seems to be growing. Do you want to speak a little bit about the trainee experience? It sounds like, you have the mothership, so you have the academic, traditional model, but then also having like the OBL partnership, and then getting like the dedicated dialysis, where I bet you just like, I bet if it's like a Fresenius partner, I would imagine that you guys are like rolling through, declots, dialysis maintenance. I mean, I bet they get pretty facile with that.
The trainee piece to this is really interesting. So I came from the East Coast, where I think some of these changes are a bit more mature. We are still kind of early in the evolutionary phase, and there's also the advantage of geography here. So I'll explain what I mean by that. We certainly, as a adult faculty group, have intentionally expanded to have kind of a differentiated procedure mix where we take care of lots of different patients and in different settings. It's professionally satisfying that way. From a trainee perspective, it's a great question. How did they get that? The ASC and the OBL are pretty early. We're not ready for trainees there yet. We're just figuring it out ourselves. Trainees here have the advantage of working here, and then they also go to Denver Health, which is a safety net community hospital, and they will see a fairly different set of pathology and context. I think they really get to appreciate how to do a lot with, I think, in a resource-constrained setting where they're phenomenal IR doctors. They work really closely with us. They also rotated the VA. They also rotated the Children's Hospital. So I think between the academic hospital, Denver Health, the VA, they really get an enormous mix of different, diversity of patients, of pathology, of settings, of approaches, of perspectives. And the other thing I want to mention from a trainee perspective is also there's we don't make enough of this, I think, is diversity of perspective within the group. IR is still pretty young, and I think we are fortunate to practice in an era where there's different ways to do things. We don't have to be led by dogma. And I think one of the advantages of our group is we've intentionally hired folks with different pedigrees, and it's enriched us. Sometimes we ask ourselves, why is it that we do it this way? Oh, because, Dr. Cumpy started it, and then Dr. Durham followed, and here we are, 20 years later. And some of those things are really well founded, and some of those things are ready for reevaluation. And having that sort of openness of culture where we embrace folks who are coming in from different institutions with different philosophies and kind of building towards a continuous evolution is, I would say, it can be a challenge, but it's also a highlight for our residents.
I actually completely agree with that. I think I've been at a couple of different training programs, like for residency and fellowship. And there's one of the institutions I went to, it was the way to do it. It was this is the way to do a port. End of story. And there was a lot of efficiency in that. There's a lot of certainty in that. But then you went to fellowship and I realized I had different attendings at different hospitals that did things just a little bit different. And they all get you the same result. And there's some that are more appropriate for different patient situations. So good for your residents. I hope they're taking full advantage. It sounds like they have their hands full with all the pathology you guys have. So biliary strictures, big topic. I know it's intentionally big, and so we don't have to cover it all, but I just want to start with an open-ended question. How do you think about biliary strictures? How do you organize it in your mind if you get a referral for a biliary stricture? How do you first start thinking about this?
Yeah, that's great. I think the first thing to think about is it a biliary stricture? I think there's also often the presumption clinically that there's a stricture involved, but really just biliary obstruction and you're working it up. So let's start there. Your typical patient you're going to get consulted on has some issues with bile backup. And often in the setting of biliary stricture, if you narrow your focus a little bit, you're sort of riding a clinical hunch that this is the biliary stricture that we all think about, right? Which is there's some scar tissue there that's built up, that's narrowing the bile duct lumen. And the vast majority of times that's true, but often it's not. So you start at, I think, a high level, does the clinical workup make sense? Does the context make sense? And could it be something else? And most often that something else is a malignant stricture, by comparison. But I'll tell you, within the benign stricture grab bag term, there's a number of different etiologies we've run into. And the more we pull for the advanced imaging tools, I think MRCP is getting really good. Cholangioscopy, percutaneous endoscopy is a huge leap forward in this space in really understanding the etiology of, is it a non-malignant, quote, benign biliary stricture? Obviously, that level of analysis comes in after we've decided to intervene. But so I'll hold off on that sort of percutaneous endoscopy perspective, but I want to mention it as sort of coming around the corner. At the outset, really, it's just clinical evaluation, and does the story make sense that there's a stricture involved, and do we think it's more likely benign or more likely malignant based on the history?
Okay. So along that thread, if we talk about workup, so somebody is sent from you, maybe from transplant, another service, and biliary stricture is a thought in your head. I kind of want to get as far as your approach, targeted history, labs, imaging that you want.
Yeah, terrific. I think particularly in the transplant setting, it's such a good framework to approach strictures. Is your non-transplant setting, it's a little bit easier, right? You typically have everything line up. So what do I mean by everything? You've got a patient typically with signs and symptoms of cholangitis. They've got, they typically have a bit less energy. They've got some nausea. They've got some right upper quadrant pain. And you've got elevated bilirubin, elevated alk phos in the labs to match, maybe some leukocytosis. Then you've got some chills, occasional fevers, right? If they're starting to extend from more localized to more systemic spillage of that disease. And you've got usually some history that makes sense. Infectious etiologies, usually that's a patient without much history, but typically, there's some prior surgery to indicate that the biliary system could be disrupted and could have some sources of inflammation or scarring. And you line that all up together, and I think you've got a sense that this is probably cholangitis from biliary obstruction. And then for imaging workup, I think most times, practically speaking in this era, they've got something, right? They've got an ultrasound, they've got a CT. And the first thing I look for is there clear biliary obstruction? If I can localize that, if I can confirm it, that goes a long way. Typically we're looking at, prior surgery, a clear prior episode of, let's say there's a patient with chronic pancreatitis, that's another common setting, right? You're looking where there's been evidence of prior inflammation and you're seeing if there's obstruction there. In terms of more advanced workup, sometimes that's not enough, right? So going back to that transplant perspective, What you really have is a conversation with your patient. Is it really sounding like cholangitis? It can be much more subtle, I think, in the transplant setting. It's not going to line up. You're not going to have clear biliary obstruction that lines up on imaging with, clearly elevated bilirubin. That's too easy. Typically, I think in the transplant setting, right, we're relying on a conversation with the patient, conversation with a hepatologist who sees them much more frequently. This is really getting to be recurrent cholangitis. I have a sense that this is related to biliary obstruction. And then that's when we pull for more advanced imaging, like let's confirm this with MRCP. Let's at least map it. Typically, I think most places, the MRCP is good enough to not only confirm the diagnosis in the cases where it's not obvious, right, where CT doesn't quite show it. You can see enhancement along the bile ducts. You can see particular foci of obstruction in MRCP. But quite frankly, sometimes you're not going to see it clearly enough. Some of these strictures, particularly post-transplant setting, most of the bile ducts look okay. There's not clear inflammation around the ducts. And there appears to be some narrowing at that anastomosis. And then you've got to lean on that clinical workup, on that clear history of, this is sounding like cholangitis. I think we need to do a PTC. And that's where I think, again, going back to the clinical workup is super important. Nice when the labs and imaging line up, but not totally necessary.
So just to go back and just for maybe some of our younger audience who missed it, but like if they came with maybe like a right upper quadrant ultrasound and the clinical picture wasn't, or the workup wasn't fully baked, if you had like to order some imaging, you would an MRCP with an MRI with and without contrast.
That's my first cross-sectional study choice. If you can get yourself to the place clinically where this is a reasonable consideration.
Yeah. Okay. But then still PTC has a lot to offer, right?
A lot to offer, yeah.
So indications for treatment, we touched on them a little bit, but recurrent cases of cholangitis, biliary stones maybe. Are there any contraindications worth mentioning?
Yeah, we run into these with some frequency. I just want to mention if it can be done endoscopically, it's not quite a contraindication, but obviously, right, endoscopic treatment is preferred, generally speaking, across the board with biliary interventions, with good reason. No one wants a catheter sticking out of the liver. Ascites is a problem. Typically, we're going to think many times before we proceed with biliary access, and typically we wouldn't in the setting of uncontrolled ascites. And obviously, you've got bleeding risk, so the INR has to be normalized or close to at least less than, in our practice, it's less than 1.8. So those things have to align as well.
One of the things that I was thinking that I just put down in my notes, one of my old attendings, he always made a point of saying it's not a contraindication, but you always want to be thinking in your mind, like, is this like a diffuse hepatobiliary process like PSC or something like that? He's like, you can think about mechanical biliary stricture, but he's like, always like have that in the back of your head.
That's really good. I mean, I don't want to, I could build on that remark just a little bit. Yeah, I don't want to take us in the weeds here, but we have a number of patients with PSC, recurrent PSC, they get a transplant in the ideal situation. But here's my sort of, I don't have a large case series to back this up, okay? But PSC is really challenging, and I don't think it's as simple as saying we can't help with the diffuse process. But the conversation is totally different, Chris. So that's worth acknowledging. Is this some diffuse process that affects multiple orders of bile ducts? Are we likely to meaningfully improve bile flow with one or two drains? That's really the thing to think about that's related, is if it's a diffuse process, to what extent can we meaningfully improve bile flow with one or two drains? The reason why I say that is, as a concrete example, I have this patient who had multiple strictures. One was right past the left hepatic duct confluence. Mm-hmm. There was a stricture in the left main duct. And then there were small strictures in the second, third order branches, PSC, mm-hmm. right? What's been remarkable about that patient is we treated the central duct stricture, and it seemed to improve the bile flow enough to where he was no longer getting the same cholangitic episodes. The labs weren't normal, but pretty close. So we pulled the drain. And about 6 months later, he clinically recurred. So this time I put in the drain through the left side and treated the left main duct. The central stricture had not recurred. And that was, Chris, now 4 years ago. So he's living with those smaller strictures peripherally, but centrally there's enough flow. And again, his bile flow in toto is not normal, but it's enough to not get him to clinical cholangitis. And so I use this case example to sort of broaden the perspective around, yes, we should be really cautious about promising a fix in patients who have diffuse disease, but it's also worth evaluating with some attention to detail, how much of the diffuse disease do we think we can fix with percutaneous drainage?
Man, Premal, I will just say that that says everything about you, as a physician. It just if I had to project of what I've heard, you sound a very much a yes guy, detail oriented, okay, yeah, the conventional teaching is you don't have much, but let's just see what we can do here. And like you said, it's not good enough, but what you're trying, you get the end result. That's great. Your patients are lucky. That's good. I like that. All right. So the next thing that I have to talk about is day of concerns. And I kind of grouped this into a couple of categories, what do you want as far as your lab workup, your choice of anesthesia, and antibiotic regimen?
Good stuff. Yeah. So labs, we typically get, CBC, PTINR, CMP. You just want to make sure that, I think it's very helpful to get a baseline bilirubin. It tends to fluctuate. Even if you know what it is, a few weeks ago, I think it's worth rechecking the day of. And it's assuming this is a new stick, we want the INR within range. So the standard lab workup, we typically get, as a rule, anesthesia involved with new sticks. Now, you can make the argument that if it's a diffusely dilated system, that's not necessary, and that's probably true, but it's really nice to have the capacity to keep a patient comfortable for 2 to 3 hours if needed, especially if it's a non-dilated system. So we always have anesthesia involved. And I find that we would prefer to do general anesthesia. You get much more breathing control. In the upper quadrant, to me, it's either you do on the lower end of sedation, or I'd rather have the patient asleep so I can get good imaging. And antibiotics, sorry, I forgot to mention. Yeah, we generally do. I mean, I don't think there's consensus on this, even in our guidelines, but we do a 3rd generation cephalosporin.
Okay, unless allergy and then...
Yeah. And then Vanc,
yep, right,
or, yeah.
How about room setup? How do you have the patients positioned? And I'll ask how you have them positioned, and then I'll ask my next question. Go ahead.
I think there's more coming there.
Yeah.
We almost always, I have the patient positioned supine. I hardly ever need much of an, oblique positioning. Sometimes you do. And I will bring up a related thing here, Chris, is I like to look by ultrasound before we prep.
That was the question.
Yeah, there you go. Yeah. There's I think there are strong opinions on whether that's offering any value, but for me in our practice, I think it's indispensable. It's super helpful to narrow your range of interest to the right space within the liver and the right approach to it.
Okay. As far as approach goes, how do you decide between right lobe access and is ever left lobe access a consideration?
Yes, I think the way I think about it is really simple. I want the majority of the bile-producing liver that's affected by this problem to be traversed by the drain. Now, you could make the argument that if it's a central stricture, you want to go with comfort, and that would be a left-sided drain. It's more comfortable not to have a drain go through between the ribs. The trade-off obviously is there's a little bit of a higher risk with bleeding issues with left-sided biliary access. Our patient population, it's not as simple as a central biliary stricture. Usually there's something close to the hilum or potentially more involved in the right lobe. And so we do much more right lobe access with the rationale that you want to get as much of the liver drained as possible.
Do you ever start your procedures thinking that this patient is going to need right and left lobe access and you'll prep both? Or if you had that thought, is your normal thought let me stage this out for the patient?
I typically, when it's obvious that they need two, we just go for it. We don't want to waste their time. There are 2 situations where that comes to mind. I think malignancy, where there's obviously involvement. Sometimes there's, benign stricture involvement in both ducts, but that's unusual. Usually that's in the diffuse setting. The other place we run into this is actually a transplant setting. It's sneaky. Especially in the era of doing a lot of live donor livers, you're going to have more than one anastomosis. It's really important to remember to check how many anastomoses there are, and really evaluate every segment of the liver. One of these patients, that comes to mind had 3 anastomoses. So do we really stage that out, wait for them to declare themselves? Do we just rely on a PTC the day of all 3 to determine whether, we need 3 drains? I would advocate for, if it's not clear by imaging, just do the PTC and make sure the drains are in a timely fashion.
So that was all my pre-op stuff, so now the patient's on the table, prepped, ready to go. Will you kind of talk about your process about like how you access and at least for me, I feel like every time I see someone do a PTC, like one of my partners always learned like a new trick or something, and I'm like, oh, that's great. And so, more detail the better on this.
Sure thing. Yeah. I start typically with an ultrasound evaluation, and I want to go as peripheral as possible. I think in the setting of even a moderate amount of dilation, you can really now get that needle into a duct. What I think without ultrasound, what you're kind of relying on is probability that tip is within duct without any ability to do micro adjustments. With ultrasound, I think you really focus in, especially with anesthesia breath holds, whether that tip is truly located within the bile duct. And even if it seems really hard, I sort of encourage my trainees to start with really small ducts peripherally and then move forward. And usually it turns out, if you're in the sort of 4th order, 5th order duct, it is too small and it's worth going to the 3rd order. But it's important not to get tempted and just go for the biggest, juiciest, central-looking duct, right? I think by ultrasound, it also is helpful to avoid major vascular structures, portal vein, hepatic vein branches. Obviously, we take them and we go through them, and it's fine when we need to, but these are just the advantages of that initial ultrasound evaluation. So yeah, I'll start with low in the right liver. I'll start with more peripheral, and then we'll probe, incrementally more centrally. The other thing to keep in mind with ultrasound is the trade-off is usually you're orthogonal with ultrasound guidance to the duct. So I find too often that it looks great by ultrasound, but then when I put the fluoro on, there's like a 90-degree angle to the,
sure.
And so just, again, not being tempted to take that, maybe that's great for the initial PTC, but then do a second stick to get a more obtuse, gentle angle that's going to be much more favorable to eventual upsizing.
Okay, nice. What needle to use for sticking?
We typically go with a 21 gauge. What I was taught early on in fellowship residency and even early in my career is really try to go with that 22 gauge. And this is, I think it probably incrementally reduces risk of complications when you're doing a lot of sticks. But, we found, especially with widespread ultrasound adoption, you can really, the safety profile of your sticks is much better. So we've sort of dispensed with that 22 gauge needle. And I find that the 21 gauge Chiba needle, you can direct it more easily, it goes in a straight line. And yeah, it works for us.
All right. So once you hit, or you think you got a hit, so you pull out style out, you get bile. What next?
Well, I will do a cholangiogram at this point, usually with extension tubing, just to allow for some degree of flexibility. And then it's time to evaluate whether we like this access to upsize or not. So in some situations, I'll take the time to do a second stick by fluoroscopy. That's much more kind of a gentle angle. But the majority of times, especially if you're proactive in recognizing really orthogonal angles by ultrasound, you can hit it at a gentle enough angle that it's time to just take it. And I'll usually just immediately pull for a nitrex wire, nitinol-based wire, a little bit softer, more forgiving. Hold on to that needle hub real tight. Absolutely. And then gently advance the wire. Yeah.
Okay, so wire goes, AccuStick or NEFSET to upsize.
Exactly. Yep.
Okay. And then, so I imagine like the first injection, contrast injection, you're not really trying to blow it out. You're just trying to see enough duct to where if you have a good stick, and maybe if you have to do a 2-stick technique, but now you've upsized, you like your position of your NEFSET. Is this the position at which you will do your real PTC or your diagnostic PTC?
Yeah.
Okay, got it.
Precisely. And sometimes it just happens with the needle. And so you take it, right? You really want to take those single shots. The other reason I really like it is easy to forget where you accessed. But if you have a good, nice save, a DSA, you have that for reference forever, where the initial injection was. Otherwise, yeah, you're right. We'll do the proper PTC evaluation once the NEFSET or whatever, transitional sheath set you have in place. And this is where it's okay to err towards a bit more distension to get really good pictures.
So this is the question. Sometimes like the teaching is, in the setting of an active infection, you don't want to blow up or overly distend the biliary system. The thought that you might, cause bacteria to shift into the bloodstream, patient can go septic. So when you talk about like, the pictures that you're trying to get without like, if you were talking to a trainee and like trying to discuss like the subtleties where like pressure injecting 20 cc's into the system versus, just kind of puffing it in, getting it in.
I couldn't have said it better. Yeah, I think it's important to not go. It's really about your slope of injection. To make it objective, I think the majority of situations you're going to have patients who have biliary colonization. They're usually, when we get involved, they're sick. So you have to be a little bit careful. It's pretty rare that we've got a complete obstruction. You're right. It's about getting enough contrast in there to understand where the obstruction is and the extent of obstruction. And the other way to sort of mitigate the risk of issues is let all of that contrast, bile, blood flow out of your access sheath. Let it pool. It's uncomfortable, right? A lot of trainees kind of naturally don't like that. They want to cap it up. And I understand it. You don't want pools of bile there, but that's your decompression. It's going to make it less likely that you run into trouble. I do think we get away with the fact that we have good antibiotic prophylaxis and their physiology is managed typically by anesthesia. We haven't run into too many issues with, it's pretty rare that we have a frankly septic patient because we over-injected. On the other side of it, if you're too gentle, I think you're missing, there's a lot of lost information. So where's the right spot in terms of the intensity of your injection, I think is a little bit of an art, but I'd say puff it in gently, keep puffing until you get a clear picture of the biliary system and where the obstruction is.
Do your cholangiogram, find your obstruction. I'll just fast forward you to a little bit. So you cross, no problems. And then take me through like what you're thinking for the next part of the procedure.
Yeah, once I've crossed, it's really, do I want to deal with this? Do I want to start the treatment now or not? And that sort of depends on the context. Typically, the vast majority of times we'll just leave a catheter and decompress the patient. So this is not universal, but my preference is to just get the catheter across, internal, external drainage, and then come back before we do any treatment. That includes ballooning or, stone treatment, stricture treatment, et cetera. Sometimes, in a scenario where you don't just get across, ballooning is necessary. Obviously, we'll pull that for that right away.
Yeah, are you talking about like you're just ballooning just even to get your drainage catheter
Exactly.
down? Yeah, absolutely.
Yeah.
Okay, so now like the crux of it is, so like you have this presumably benign stricture. I do want to come back to the endoscopic evaluation, like when that plays a role. But I guess I wanted to get at like, so how do you manage it? Do you guys have like a biliary stricture protocol? Does everyone have their own? That's what like kind of what I want to get at. Like how do you then approach it?
Yeah, I think having a protocol-driven process is super helpful here because there's too much subjectivity, I think, and it's very easy to get caught up in, I'm just doing this thing now and I'll worry about the big picture later. So the protocol prevents unnecessary variation and I think reduces the number of decisions you have to make in game time. Our protocol is, 10 French by design at the outset. It's unclear enough whether you've got a benign stricture. It's a reasonable time to go ahead and do some sampling, typically with a brushing at that point. The more chances you have at brushing, the better, right? And so if there's a question about malignant obstruction, I think I would just do the brushing then. And then our protocol is every 2 weeks, upsized by about 4 French. So the goal for a benign biliary stricture is 18 to 22 French. I typically get to 18 French. You want to get there, I think, in about 4 weeks or so, 4 to 6 weeks. So every 2 weeks plus 4. I will say there are institutions that do it differently, and there are probably scenarios in which you want to do it differently. So you could come back the day after or the day, within a few days and upsize, right? What's the advantage of waiting for the 2 weeks? I would say the chance of pain and liver laceration lower if you stage out the upsizing. And I found that 4 French or so is roughly the right amount. If you go 6 French, could you do it? Absolutely. Our nephrologists do that with the kidney. Some others, I think upsize much more quickly than we do. But I think the trade-off is pain. I think in general, I found the patients are much more miserable that way. Now, what are the scenarios in which you want to you accept that pain point, if you will. In Colorado, especially, we've got a geography where some of my patients are driving 7-8 hours, Chris, to come see me. Then I feel bad about whether, do I really want to have that kind of expense devoted to an upsizing? Maybe you go a little bit more aggressive. Or if you're worried about, socially, economically, if that patient can come back, get them up to size as quickly as possible.
And if you're going, from day one's 10 French, 2 weeks later, you're heading to 14 French, any kind of angioplasty the day of the 14 French upsizing.
This is where, we haven't protocolized that part. And there's some thought to doing a plasty every time. I think that's totally fine. I typically don't. I'll get up to my 14 French and then 18 French. The old literature going back to how we started doing this was just plasty. And the rationale was just plasty every time you see the patient, and that's doing something. And I don't think that's wrong. We typically reserve it for the last upsizing before we're going to not see them for 2 to 3 months. Or that's the maintenance phase of the protocol. That's not really based on concrete ideology.
Okay. So you've gotten up to, so your goal is to get to 22, and patients coming back they're going from 18 to 22. So this is going to be their last one. So what does that session look like? Is that the session where you get them up to 22, but you're also doing plasty?
Exactly.
Okay.
Yeah. And it's a range.
Sure.
The majority of our patients stay at 18 French.
Okay. Got it.
So 18 is good enough. That's our definition of large bore. And so, we will typically do, if the stricture is tight, we will definitely plasty much more aggressively, maybe at every visit. And, 8 millimeter, 10 millimeter plasty, once you if it's a central stricture, you got to, I think, work a little bit with what you have. If it's a peripheral duct, but it's really big, you can get away with that 10 millimeter plasty, even peripherally. But typically, in most livers, you can. I think you got to go more on the 6/8 side peripherally. And then the other thing I'll mention about plasty is really effective it is necessary for ducts that are adjacent to the drain that you're not going to treat with the drain, right? Sometimes these strictures are complex. There's one main stricture, but like a duct adjacent to it doesn't quite look right. That's where I'll do the plasty, every session until it kind of, the other adjacent ducts look more like normal caliber ducts.
Okay. And choice of balloon, just regular POBA?
Regular high pressure, whatever you got.
Yeah. Any role for cutting balloons in your practice?
No, I think there's some literature for cutting balloons. I think there's good rationale for them. There's just not good outcomes data. They're not really designed for the biliary system, right? They're designed for the vasculature.
Sure.
I don't think they do the same thing in the biliary system. So I've pulled them out occasionally where I've got this recalcitrant stricture. I try everything and it's not working out. I'll try the cutting balloon. But I haven't found it to make a big difference. And I think ultimately the kind of incision you make with them is not sufficient to really get through really dense scar tissue.
Okay.
Yeah. And we don't have the same kind of long-term outcomes data with cutting balloons either.
So if I can back up a little bit, and not to open like the biggest can of worms, but at what point, where is the role for endoscopic evaluation, or basically endoscopic anything? Like where does that add in? Like where's the value add in that process?
This is the question, I think, of the episode, Chris. And I would have answered this very differently a few years ago. But the more I do endoscopy, the more I realize that our definition, let's just go back to the very topic of this conversation, a benign stricture. Well, how do you know it's a benign stricture and what does it mean? I mean, I think typically we're relying on a certain appearance of narrowing to surmise that it's that type of stricture. But, I could show you lots of pictures. It's too bad we can't here, where it looks like a classic benign stricture, but it's actually not scar tissue. It's something else. There's a stone there. It actually isn't intrinsic to the bile duct. There are other etiologies that can cause problems that similarly result in the appearance of biliary dyskinesia and cholangitis. And so what I'm saying is endoscopy is such a higher sensitivity evaluation for what the problem is. And we are a bit naturally married to 2D fluoroscopy. That's where we come from. It's a good initial stratifying tool. But if you've got endoscopy, you can do a much more higher sensitivity evaluation of what the problem is. It can also, I think, help you sample the area with a targeted biopsy in a way that I think it's a bit more random by fluoroscopy. So the answer today is, I think if you got the endoscope just confirm that it's a benign stricture and not something else.
Okay. So it sounds like your threshold's getting lower and lower these days.
Yeah, exactly. And I will say, I typically don't use the endoscope to confirm diagnosis at the time of placement. I like to have a mature tract.
Okay.
Now, you don't always have to have it, but if you're on this benign protocol, right, you're going to have the patient come back 2 weeks, 4 weeks. They've got a mature tract by then. I just wait till that second or third visit to confirm diagnosis.
So as far as like the blocking and tackling of using the endoscope, like what size sheath do you have to have in? What kind of, like if you can give like just some of the details without having to get too far into it, but if you can paint a picture a little bit about what the endoscopy practice looks like.
The size, as soon as you have a 10 French access, you can make it work. The majority of endoscopes are about in that range, like 9 to 10 French. It's challenging to work through a sheath that's just large enough to accommodate the endoscope. The endoscope is made for, multiple degrees of freedom. So you want some space around it to navigate. But if you absolutely needed to, right, you're in some situation, the answer is get me a 10 French sheath and I'll put the endoscope through it. And you can even put it over the wire to where you need to evaluate, pull the wire out. And then you don't have to get into all the navigational aspects of endoscopy, which can be challenging. My preference is to get up to that 14, 16 French range. So you got a few French around the endoscope, not only for ease of movement, but also irrigation. Then when you irrigate, which is a crucial part of visualization, there's an opportunity for all that irrigated saline to come back around the endoscope out the body rather than all being dumped into the bowel, which, has obviously a diarrheal effect. So yeah, basics, you need at least 10 French, but I would recommend get up to that 14 French if you can. And then, yeah, there are a lot of options these days in terms of what equipment you use, what type of endoscope, et cetera.
Is your preference to, like, so you have your wire down, to advance the endoscope, like maybe a little bit distally, like over the wire, and then do more of a pullback evaluation? Or do you like getting into the bile ducts and then kind of navigating down, maybe alongside your wire? I'm just curious about how that part works.
Yeah, I think you'll find, like for folks who are just starting or thinking about starting, you'll find that you ditch that wire quickly because it restricts your endoscope. Ultimately, you want to start, once you got some comfort about how you can move up, down, left, right, you really, I go bare, it's just, I'm going alongside the wire and navigating down the bile ducts. It lets me see what the normal ducts look like. And you're absolutely correct. The best way to visualize the problem area, which in this case, we're talking about a stricture, is to go beyond it. And then as you're coming back, slow up and really intensely irrigate to get that lumen to not crowd your endoscope. You need a little bit of distance from the endoscope tip to where that tissue is to see it well. And the best way to do that is that pull back and then irrigate intensely as you're doing it.
Will you give me a couple of examples where like you did endoscopy and you were like, wow, it doesn't have to be like a total shock, but like you mentioned, like there was a stone or something you thought was a benign biliary stricture, but like endoscopy gave you something different that helped change things.
Yeah, absolutely. I think I was fortunate because when I started, I had a number of patients that were referred to me who had failed kind of conventional approaches. So there was a selection bias towards, this is maybe not a typical stricture. And it wasn't even maybe the second or third time we were looking at reevaluating the diagnosis with an endoscope. Like I mentioned, there was a patient who for a while looked by cholangiogram like it's a classic benign stricture. And what we had is a stone that had formed around a suture that had gone into the bile duct right at the anastomosis, right? So now that suture is kind of hanging there and it's collecting bile crystals, and those crystals are becoming a stone and had matured into right, that patient was never going to pass a normal stricture protocol. And the way we dealt with it was we took care of the stone with a laser, and then inside that stone we found a suture and then, cut the suture. That's an example of we would have never succeeded because our standard protocol didn't allow us to diagnose it correctly. If we had pulled the endoscope to begin with, right, we would have saved them like 9 months of pain with a protocol that never would have made sense for that patient. I want to bring up one related thing about a aha moment, and I'm not sure I have like answers to it. So it's just going to cause a little bit of discomfort, but I'm going to say some strictures that look like strictures by cholangiogram, there's no scar tissue there. And You can really confirm it by standard endoscopy. They have this thing where you can highlight microvascularity. So you can look at tissue, and if it doesn't quite look like white scar tissue, you can put on this feature of an endoscope that identifies microvascularity to just see, is it like a bunch of pale tissue that's not getting blood? And you don't see that either. And I don't know how to explain that, Chris. I think what it's led me to understand is that the benign stricture bucket, the vast majority of it is scar tissue that's going to respond to remodeling. But some of our failure rate is just because it's some other etiology that we don't understand well enough yet.
Okay. Well, that's cool. I haven't adopted endoscopy in my practice, but whenever I talk to people that have like worked it into theirs, Smearintopolis is doing a lot of gallstone treatment. A lot of people are using it in the biliary world. It just seems like such a cool thing to have in the toolbox, that to have it for a go-to, like for further evaluation, and then all the treatment options that it opens up. Like the IR doctors that are coming out now, I'm sure like your trainees are going to just be like, oh yeah, endoscopy, no big deal. Like I do that all the time. It's like these super IR docs.
If I can normalize that for everybody, that would be, I think we'd move patient care forward in IR. I think it is truly possible for everybody to develop a base level of comfort with endoscopy. We don't want to supplant gastroenterologists. This is a completely different thing. It's kind of akin to how GI doctors use endoscopy, but they also have fluoro in their labs.
Right.
Well, can you imagine not having fluoro as a GI doctor? No. I think that's it's an adjunctive tool that lets you, at least in a very basic level, classify the disease you're looking at or ask enough questions to pull in an expert doctor. And I think the majority of us can get to that level of facility with an endoscope. The challenges around credentialing, access, I think are a little bit institutional specific, but I will say in general, those barriers are being lowered too, because it's much more normal now for percutaneous endoscopy to be seen as a viable thing in most institutions.
Right. I like to hear this. All right. So going back to the patient who's now at their last dilation segment. Oh, one of the other things I wanted to ask you about, like if you're going to plasty, the duration to which you keep the balloon up. Standard.
Yeah.
Okay. Yeah, go ahead.
Yeah, it's a good question. Our practice is 3 minutes. It's a more prolonged dilatation than you would do in the vasculature.
Okay. Got it. 3 minutes. And then, so for the last session, plasty, you have the 18 French drain in, then what's next? Like what's next for the patient? Like how long does that kind of dwell?
That then stays in. I'll try to space out the next exchange to about 3 months, 2 to 3 months, to minimize their repeat visits. And the total time, protocolized time, is 6 months at a large drain. So it's important to get up to that large size as quickly as possible, not to lose track with, here's a 10 French, let's just exchange for a 10 French. It's doing something, but it's not doing enough. So 6 months at 18 French is our protocol by default. We'll make some alterations occasionally as needed for patients.
And then when they come back for maybe not the first exchange, but the second exchange, they've had it in for 6 months. What does it look like as far as like, can this drain get pulled, or does it have to dwell another 3 months?
In patients who are tolerating it, I'll have them dwell it for another 3 months. And I'll say it's not based on anything good. Like I don't think we have data to say that 3 months is insufficient, but we do have data to say that 6 to 12 months is sufficient. I will do that if it's feasible. And most patients by that 3 month visit are so used to the drain. Yes, they have pain, but you can address it. And there's enough healing around the liver that it's doable. I just saw a patient yesterday who was so miserable with her drain that she could not have tolerated 6 months. So I did that same evaluation. Is there enough flow of bile through the treated ductal segment? And then we could talk about what the final evaluation looks like. But if the cholangiogram looks close to normal, then I'll do a 2-week capping trial and pull the drain.
Okay. Yeah. So let's talk about the final drain evaluation. Like, how do you do that? Is the drain in place? Is it out of, or you do it through a sheath? Curious.
Before I skip over this, at that 3 month visit, I'll do a sheath cholangiogram. And that's really, I think it's super helpful to really look closely at the stricture and see if it's responding to catheter treatment. If it doesn't seem to have done much, that's a good time to, again, do some prolonged cholangioplasty to move that process along. And again, the same thing at the 6 month visit is a sheath cholangiogram and look at how much it's remodeled, how open it looks. If it looks pretty close to open, then I'll do a shortened biliary catheter usually cap it in about 24 hours and just let it be, no flushing, just ignore it for 2 weeks. See if the patient could tolerate internal drainage on their own, and then pull it in 2 weeks.
Did I miss anything about, like, as far as Yale's protocol goes? We talked about plasty, we talked a little bit about endoscopy, and then how long you keep the drains in. Did I miss anything?
No, the third rail of biliary interventions is the Whitaker. I think there are strong opinions, but I don't know if we really want to get into it. We did it much more systematically a few years ago, and we found when we evaluated the data that it was not particularly useful.
How about this? Why don't you describe the Whitaker, and then people, after you having described it, they can decide if they want to go down that rabbit hole.
I don't think they want to do it, I'm telling you. But I hardly have to describe it. The Whitaker, the idea is you do set standard injections of lower viscosity contrast, 50-50, and it's really gentle injection over a minute. What it's doing is gently building up pressure in the biliary system, and you're doing a pre and a post pressure by just all through the catheter or the sheath that you're doing it through. And the concept at a big level is you go through this protocol and it's telling you if the biliary system can handle increases in pressure, or it really increases in volume. If the increased volume of injection results in a big increase in pressure, then you're sort of picking up that there's going to be a physiologically significant narrowing. Now, it all sounds good, but I think the execution is really difficult. And the thresholds for calling it abnormal are not based on like super robust data, so there can be conflicting information. So what are you going to rely on, like a number or the fact that the patient did well for 2 weeks? I think I rely on clinical physiology.
Sure. Okay. I think that's well said, and maybe enough for the moment. Like, for the audience that's thinking about what are these guys going to talk about, stenting, or stenting going to come up? We are going to talk about stenting, but not in this episode. I want to cover that one. Like I said, biliary strictures in and of itself, biliary obstruction, biliary procedures, it's a big topic, and so we're not going to cover it all. I did want to but wind down with complications. I think like there's a whole subject of like tubology, but I just wanted to kind of open it up and say common complications that you guys see in your practice and kind of how you tackle them.
Yeah, I think most of us are going to run into bleeding complication with biliary access. And again, I think if you can use ultrasound at the outset, you can lower your risk of issues by just at least, avoiding the major vessels along the access. If it's a venous bleed, we will, upsize. If it's an arterial bleed, it requires, you've got to know, kind of sense it ahead of time based on how the patient is acting, how much bleeding there is into the bag, their alteration in physiology, et cetera. And then we'll just go with the expectation that we're doing the angiogram to confirm that there's an arterial source of that. Important to remove the catheter over wire and repeat, arteriography to confirm, to really do a higher sensitivity evaluation for bleeding. It's amazing how often we do biliary access and how few complications are. Obviously, non-dilated central sticks, much higher risk, and we counsel patients for that. But in a center where we are very frequently doing non-dilated PTBs because of our population, our rates of a significant bleeding are very, very low. It's really single digits.
That's great. One of the complications that it's just a small complication, but I feel like it comes up all the time in practice, is just tube leakage or, bile leakage along the tract. Without like going into that whole topic, do you have a couple words of wisdom for people like our patients that are struggling with that?
Yeah, that's a really good one to not forget. So I think this is where attention to detail can really help. I'll mention two things. One is you really want to cover the majority of the access biliary system with the side holes. There are enough manufacturers that I think make drains with too few side holes. And if you're excluding too much of the peripheral liver, then the path of least resistance is around the drain, especially as you mature that tract. So really paying attention and getting side holes through much of the access system is helpful. There are different manufacturers again, but look, I think there are certain drains that have larger side holes, and that can make a difference in terms of how likely the bile is to flow through it rather than around it. The other thing to think about is occasional but really relevant. Some livers are just not large enough to accommodate a large drain. So when you get to, especially in PSC patients, sometimes the problem is that there's a 16 French drain, and really what it can accommodate is a 12 or 14 French. And you've got to think about whether you're occluding the biliary system because of how tightly that drain is sitting in the bile duct. The bile duct is too small. That occasionally shows up as leaking with a mature tract, but it's actually more commonly that you'll see that as sort of a persistent cholangitis, sometimes this like smudge that comes out of the drain. Again, just paying attention to size of the duct and ensuring that you've crossed the right amount of the biliary system will keep you out of trouble there. And then the other thing I want to mention is so many of these patients have pain, and looking at doing intercostal nerve blocks, it can be, the block only lasts a few days, but it can be hugely resetting. And I can't quite explain it, but if you can sort of stop that pain cycle with a nerve block, so often in the patients who are most affected by having the drain in, doing a block will set them again up for a month or two between exchanges.
Is there any advice that you have as far as like when I know sometimes it's hard to pick your sonographic route based on like where the rib is. Sometimes you're just trying to get the best picture that you can. But if you had like your abs, like if you could put it anywhere, do you try and have it like equidistance between ribs? Do you try and just go over one rib? Like what's your strategy as far as like the tube in relation to the ribs?
Yeah, I think just avoiding really grazing on the rib is where it's at. I think ideally, I want to go right on top of the rib, but in reality, that space between the rib is good enough. And certainly patients who are really skinny, they just don't have enough fat and space between ribs. Nothing you do is going to be enough. But where the worst, I think, pain happens is you've grazed across the rib and now you're upsizing and they just have horrendous periosteal reaction and pain. And so avoiding that, sometimes it's already happened, right? And patients are miserable. It's not too late to retract. You can see that thing grazing along the rib. Go ahead and hit the same track again with a new access that avoids the rib rubbing.
Whenever you're blocking the rib, like say you went just over a rib, like so you're just over rib 12, are you blocking rib 12 or do you block rib 12 and 11? Like,
yeah,
I'm getting a little confused.
I've always done above and below.
Okay, yeah, I think I would too.
The one that's above is the right answer, but I usually get two levels just because I don't quite understand a priori whether that rib below is also kind of pissed off. So
okay. Yeah, that seems like, I think I would tackle it exactly the same way. I just block both. All right, so we're kind of getting to the end, and Premal, what I'll ask you, I have final thoughts. I also have resources. Like there's plenty of audience members who are trainees, and we have medical students who listen to this. Any resources that you found helpful, or maybe that you've even penned, or anything you can steer people in if they want to learn more about the topic?
There are a lot of great publications, I think, on this topic. I would recommend seminars. I would recommend techniques in IR. I learned a lot, going through those sources. Some of the more recent literature, we actually, not to be self-promotional, but I think we recently put a review together for management of benign biliary strictures for just a few months ago. So if you search for it as a review topic, you're going to see lots of relevant stuff. And then a lot of the innovation in this space is really through, keeping up with it is going to be through folks like you, Chris, we haven't even talked about laser stricturotomy. Some of the more advanced techniques haven't quite made it into that mature literature, but that's where the podcasts are really good. Going to SIR, attending workshops, that'll help you go from kind of a base platform to how do we really push the agenda and develop new skills.
You actually kind of talked on what I thought you'd hit for final thoughts. So like if you can see like the biliary management picture in 5 years, like where endoscopy's going, where you maybe RFA, laser, like where do you think like we're going to have some more tools in the tool belt?
I think so. I think every year at SIR, the number of people who are using the percutaneous endoscopy seems to be growing. I think there's a real movement, and my hope, my dream is that 5 years from now, it's doubled, it's quadrupled. It's the adoption phase will just accelerate and multiply from here. So more endoscopes everywhere, and I think there's going to be an inclination towards confirming the diagnosis with endoscopy. And stone treatment is, I think, a desperately needed for our patients. These are patients who don't easily have access to relevant treatment with our GI doctors, and so we can own it. We can fix it for them. Treating stones in the gallbladder and the common bile duct and the, peripherally in the system. And you don't need complicated training or complicated tools, in my opinion, to get that kind of stuff done. So that's what I'm looking forward to, is I think an advancement in the biliary space with adjunctive use of the percutaneous endoscope and some maybe EHL and laser.
Okay, I like it. All right, well, I think that's a good place to put a pin in it. Premal, thank you again for coming back on the show, I should say. To our audience, thank everyone for listening. We'll see you next time on the BackTable podcast. Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz. Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.